So welcome to everyone. I know we have an audience from across the globe. My name's Elizabeth Nichols. I'm one of the physicians and the GAMMAPOD lead at the University of Maryland School of Medicine, Department of Radiation Oncology. I was involved in the clinical trial that led to the FDA clearance of the device in the United States and currently lead the program at the University of Maryland. So thank you for having me today, and we'll go ahead and get started. So I have no disclosures. So this will be our outline for the talk today. So first we'll talk a little bit about just the background and the rationale for partial breast radiation, and specifically with why the GAMMAPOD may actually be superior to some of the other techniques that are out in clinical practice and clinical use. We'll share some of our initial clinical experiences, and currently the device is only in clinical use here at the University of Maryland in Baltimore, as well as at UT Southwestern in Dallas, Texas. We have additional sites that will be coming on in the very near future here, but we will take a moment to share some of our initial experiences with everyone today. We'll talk a little bit about the technology, the overview, and the workflow. And again, this can be very specific to each different institution and the setup of the institution. We'll talk about a couple different case studies. So basically, who are the patients that we're using this treatment for, and then finish up with a little bit on our clinical outcomes and our research portfolio as well. So in terms of the background for APBI, so I think most people are probably familiar with these two large randomized clinical trials, NSABP B39 run in the US and the RAPID trial run through Canada, which really, I think, gave us some great data about the use of partial breast radiation compared to whole breast radiation. And as people probably well know, in both of these studies, the rates of ipsilateral breast tumor recurrence was quite low with partial breast radiation when patients were appropriately selected. And so these are both of the graphs from the figures and from the papers that have been presented previously. With that being said, though, one of the things I think we all have talked about is even though we found great rates of control, the offset of this was potentially a decrease in cosmetic outcomes. And so again, this is from the RAPID trial, and on the left here is the APBI arm, on the right is the whole breast radiation arm. And in this figure in particular, we have the nurse cosmetic rating at the top and the patient cosmetic rating at the bottom. And what we saw is that overall the poor to fair cosmetic results were about 31 to 36% at 7 years, which was much higher than what we would expect to see with our whole breast radiation. Similarly, in the NSABP B39 study, again, when we compared that cosmetic outcomes with partial breast radiation versus whole breast radiation, again, we also saw higher rates of poor to fair cosmetic results, again, compared to whole breast radiation alone. And so a lot of the discussion has been, well, how can we really improve upon these cosmetic outcomes? And there's been lots of discussions about changing the dose and fractionation. So is this an effect of the BID treatment that's being delivered? Additionally, another way we can improve upon this is by changing the volume of the tissue that's targeted. And we have many retrospective studies that have actually shown and correlated the amount of radiation that goes to the normal breast. So the higher that is, the higher the incidence of poor to fair cosmetic outcomes. So what are some of the things that we can do to fix this, which are afforded to us with the GAMMAPOD program? So one is immobilization. So of course, if we can immobilize the breast better, we can actually use a smaller PTV margin. And specifically for the GAMMAPOD, we actually use a 3 millimeter PTV margin. What about also using smaller CTV margins, specifically compared to external beam radiation? Is this something that we can do to improve upon that? And then also looking at daily image guidance with built-in adaptive planning. So let's say you have a large stroma that's starting to shrink during the course of therapy. Can we actually shrink our tumor volumes and target a smaller area? And all of these things are afforded to us with the GAMMAPOD program. One of the very common questions, though, that we often get asked is, well, how does this compare to, say, a Varian Edge or a machine that has micro MLCs? And so I'm going to put in a shameless plug here in that we looked at this. We have an Astro poster that will be presented in the next couple weeks here. And this is actually a patient of ours who was on our boost protocol. And so this is actually the same patient. So this is what their boost volume looked like with GAMMAPOD. And so you'll see the immobilization device here, which we'll talk a little bit more in a couple minutes. And this is that same patient in the prone position without the immobilization device. and you can see how a much larger area of the breast is targeted, even with the micro MLCs that are afforded to us with these machines. So what are some of our initial clinical experiences? So at the University of Maryland, our program initially started in 2015, where we were actually accruing to what we call the BOOST trial, which is the one that led to FDA clearance. So we enrolled patients from 2015 to 2017, submitted the data to the FDA, and then we did receive FDA clearance at the very end of December in 2017. After that, we actually resumed treatments again, not until November of 2018, and this had a little bit to do with just our facility and that we needed to do a source exchange on the GAMMAPOD, do some room renovations, and we also, our device is actually co-located with our Gamma Knife unit, which was also being replaced at the same time. So that was the reason for the gap there. To date, so as of Monday of this week, we've completed 40 complete treatments for partial breast radiation in the adjuvant setting. We've completed 37 boost treatments. And then we've also done some treatments in two more definitive settings, one in a patient who had an angiosarcoma metastasis to the breast, and one patient who actually had an intact breast tumor, but also had metastatic disease, and that was their only site of disease that was actually growing. So really in both of those patients, which I think are very interesting, more definitive doses of radiation therapy. So in total, again, not accounting for our original trial, we've had now over 243 treatment deliveries in that time frame. So UT Southwestern, so they started treatments in March of 2019. To date, they said they've had about 35 patients who've been treated with a partial breast protocol, about 24 patients treated with the boost protocol, and 2 patients treated in another manner, accounting for about 200 treatment deliveries as well. Just in terms of the technology overview, so again, the unit was invented in our department. Again, it's really a first of its kind radiation therapy system in the world, really designed specifically to target early stage breast cancer. The history of the technology in terms of its development is that in 2006, this system was patented and invented by Dr. William Regine and then Dr. Cedric Yu. In 2007, they received a $3.5 million NIH grant for the development of the system. And as I mentioned, the first clinical trial was launched at the University of Maryland in 2015, leading to FDA clearance in late 2017, early 2018. There are really 4 different steps to the clinical workflow for the unit, which you can see here. So the first is the cup fitting, where we actually will fit the cup to the patient and establish suction. We then perform CT scanning with the cup on for the patient. So the patient will step up onto the image loader here. The patient then places the breast through the hole, and then this whole machine actually kind of lowers the patient down into the horizontal position. Patients then undergo treatment planning, and we'll talk about each of these steps in a little bit more detail, and then treatment delivery as well. So there's really 3 different components to the immobilization device. So there's what we call an inner cup here, which you can see, and there's a small, a medium, and a large cup. All of these actually have perforations in the anterior portion of the cup through which the suction is established. We have an outer cup, which has a built-in stereotactic fiducial wire, which you can kind of see there. And then you can see the little cord that then kind of comes out to establish a suction, again, with small, medium, and large sizes. And then we have a silicone flange that actually holds the whole unit together, and this is actually what's touching the patient. Now, as you can imagine, not every woman's breast is in this exact same shape and size, and so we do have silicone fillers that we can put in, and we have a variety of shapes and sizes to actually make sure that there's no air gaps for the patients during the treatment. So this is the general procedure that we use to actually perform the cup fitting. So there's actually a measuring device that we can use to estimate the outer and the inner cup sizes. I will share that this is definitely something that just with experience is easy to do just by looking at the patient, but sometimes you do have to fit a couple different times. Generally speaking, especially if the patient has a pendulous breast, we'll have them kind of bend forward so the breast is hanging in the prone position, and that way we really reduce the inframammary fold for the patient. We get a sense of the cup filling, and ideally what we're looking for when we're doing this is less than a 1 centimeter gap between the breast and the edge of the inner cup. That seems to be kind of the right distance where the suction can then establish itself. But again, there's often areas where there can be more than 1 centimeter, And so in that case, we will add one of the silicone boluses in. We then attach everything all together. And then again, early on, one of the things that is hard to teach, especially for my trainees, but the cups actually have kind of these pegs in them, which help align the breast with the table. And that's also how we use our locking mechanism. And so early on, it can be challenging to make sure that those are in the right directions. And so early on, we usually counsel people to actually kind of put marks on the patient, so you can do that very easily. But again, with clinical experience, it's easy to do that without making those marks. And then again, once everything is aligned and looks good, we are able to remove kind of the paper, so that then that exposes kind of the adhesive on the pink flange, and then place that onto the patient. We generally try to remove all the air bubbles from the pink flange, and occasionally, depending on the patient's body habitus, we may or may not add an additional tape just to make sure that the seal is good. And then we start the vacuum suction. This is actually a picture of one of the old pumps, so this is not what the pump looks like now, but kind of a similar style. And we look for the pressure to go up to about 140 to 150 millimeters of mercury. Now, just for reference, that is not something that's painful for the patient. So if you think about a commercially available breast pump for a nursing mother, it's about half of the pressure of that. And then we typically evaluate patients for any sort of pinching sensation, which is pretty rare. If there is a pinching sensation, it typically means there's a skin fold that we can correct, and then we move forward. One of the things that's important is, if possible, to try to only apply the adhesive once. So we often kind of put the cup on and off a couple times with the paper still attached before we actually remove that, because again, once you have some glue on the patient, it can be hard to kind of remove that. And then we also find that the inner cup size can also sometimes be influenced by tumor location. So sometimes if you're really looking for the breast to fall forward a lot more, you might use a slightly bigger cup with a bolus compared to a slightly smaller cup. But again, this is all very dependent on each patient's breast size, shape, and the location of the lumpectomy cavity. When it comes to treatment planning, so again, all of this is done in concert with our medical physicists. We review the images and then transfer them to the GAMMAPOD treatment planning system. Once this is imported successfully, then you'll remove the patient from the image loader table. And then at least at our institution, and I'll talk about this a little bit more in a couple minutes, we then escort our patients down to the GAMMAPOD unit, which is on a different floor, at least at our facility. One of the things that we do tend to find is that patients really can't sit once they have the cup applied, because once the patient's sitting, especially for shorter patients, you get a skin fold that can actually release the suction. So one of the things when we're thinking about appropriate patient selection is to make sure that it is a patient who can walk a little bit and also stand for at least 20 to 30 minutes. But I always jokingly counsel my residents that, as long as the patient's prone, you're not going to lose the seal at all. And again, this is one of the things that's a quick learning curve, where once you start to do it and do it well, patients don't lose the seal once you've applied the cup. Once we import the images, there's a rigid registration process that happens and will automatically dictate both the inner and outer cup sizes in the treatment planning system. And then as the physician, again, you're going to contour your target with the appropriate expansions. The treatment planning system will create the plan, which generally takes less than 6 minutes. And the plan, again, can be optimized just like our normal treatment planning systems against the skin, the chest wall, and so forth. And then, of course, once the plan is approved, it would be transferred to from the treatment planning system to the treatment console. So this is what a typical scan would look like. So what you can see here is the inner cup, which again, in this example, you can see the breast is actually filling the inner cup completely. The outer cup here is this kind of line here. And then again, you can actually see that fiducial wire that's part of the outer cup system. Again, you can see here the physician actually contoured out the GTV and the CTV. And then one of the interesting things that the system does is you can see this kind of orange line here that actually encompasses what the system thinks of as the whole breast. And so this is basically the area that's within the cup from the treatment planning system perspective that can actually be treated. So one of the challenges can occasionally be for these patients is that if you have a woman who has a lumpectomy cavity kind of out here, You sometimes need to offset the cup placement a little bit, but occasionally there are patients specifically with, say, an axillary tail lumpectomy cavity site, which can be a little bit challenging for the system to treat. Again, this doesn't happen often at all, but occasionally does happen. This is an example of the treatment planning system and what a plan would actually look like. So you can see we can do a lot of different isodose lines. This is what the whole patient would actually look like. All right, and this here is the treatment planning table, and then again, this is actually the image loader, which you can see in this location here as well. This is another example of a different type of treatment plan. So the yellow contour here is the GTV, the green the CTV, and the red here is kind of your 100% isodose line. The purple and the blue here are actually your 50% isodose line, and so you can see it's really quite conformal. So at University of Maryland, again, some unique things that we have in terms of our clinical workflow is that our CT simulator is located on a separate floor from our GAMMAPOD unit. So as a result, one of our patient selection criteria is that our patients do need to be able to walk a moderate distance from our CT simulator to kind of an elevator, down a level, and then to our GAMMAPOD unit. We also perform our contouring in RayStation, which is our treatment planning system that we use for all of our photon patients, and then we export our contours to the GAMMAPOD treatment planning system where the plan is then created. And for us, one of the things that we find is actually nice is that by the time the patient arrives to the GAMMAPOD suite, typically as the physician, we've already completed our contouring and we're already starting the planning in the treatment planning system. And so from the patient perspective, we found that to be nice because their perception is that they're not waiting very long before starting the treatment. So in our institution, when we look at these different steps, typically the cup fitting takes just about 5 minutes now, again, just because we have a lot of experience. CT scanning also takes 5 to 10 minutes. Treatment planning from start of contouring to completion of our plan approval takes about 15 to 20 minutes. And then the treatment delivery can take 15 to 25 minutes, again, because our sources are a little bit older, say, than UT Southwestern's. So all in all, from start to finish, it takes about an hour for us.
Good, how are you?
In terms of the clinical workflow at UT Southwestern, so there what's nice is that their CT simulator is located right next door to their GAMMAPOD unit. So unlike us where we have to make sure our patients can walk a little bit of a distance, they don't have that issue. Again, they perform cup fitting and CT scanning as previously described. They also do their contouring in a separate treatment planning system and then export those contours into the GAMMAPOD one, although they're using Eclipse to do that. And then at UT Southwestern, their physics group has developed an in-house additional QA step, which is run on each plan after the plan approval and prior to patient treatment. And so this does add about an additional 10 to 15 minutes, which is mainly data transfer from the GAMMAPOD treatment planning system to their QA server, performing the QA calculation and document generation, and then the patient goes on to treatment. This is the setup at UT Southwestern. So the GAMMAPOD unit is actually kind of through this door here. You can actually see a quick picture here of their image loader. And you can see here in this diagram, this is where their CT scanner also is located. And so the team actually stands out in this area here during the treatments. So moving on to some case studies. So the first case I wanted to present is a patient of ours who received APBI. So this was a 76-year-old female who underwent routine screening mammography, which showed suspicious microcalcifications in the 1 o'clock position of the left breast. Biopsy was performed, which showed DCIS that was grade 3, ER/PR positive. She had a lumpectomy performed, which showed a 1.8 centimeter area of DCIS, which was grade 3, and she had widely negative margins. The different treatment options were discussed with her, including observation, whole breast radiation, and partial breast radiation. And in this particular patient, she was really not interested at all in taking any sort of hormonal therapy. So we thought she would be a good candidate for partial breast radiation. And so she enrolled in our multi-institutional APBI study and received partial breast radiation delivered every other day. So this is this patient's treatment plan, which you can see here. And so in the yellow and the green here are actually our CTV and our PTV. And the red line you can see is very conformal around the yellow here. And then this purple line here is the 0.5 gray line. So you can see it's a very tight and nicely conformal plan for this patient. This is another patient with a target in a different location. And I also picked this one so you can kind of see that the dose can still conform around a unique shape. So you can see that in this figure on the left here. And then another patient to the right, these images are of a lesion a little bit closer to the chest wall, which you can see as well. The next here is a case study on a boost patient. So this is a 68-year-old female found to have a new mass in the left breast at the 11 o'clock position in the periareolar region. She had a biopsy which showed infiltrating ductal carcinoma that was triple negative. She had a lumpectomy and a sentinel lymph node biopsy performed, which confirmed a 1.5 centimeter infiltrating ductal carcinoma. She had clear surgical margins and negative sentinel nodes. So she received adjuvant chemotherapy and then was recommended for radiation therapy afterwards. This patient enrolled in our multi-institutional boost protocol, where she received 8 gray and 1 fraction to the tumor bed or the lumpectomy cavity, followed by whole breast radiation and a hypofractionated course. She did receive the boost and then went right into her whole breast treatment the following day. And so these are her treatment plans here. So you can see kind of the lumpectomy cavity target drawn out in yellow or bright yellow, kind of a fluorescent yellow, and then green. And then this was her whole breast plan on the right. She was treated in the prone position with opposed tangent fields. And then the last case study here is actually a patient who we truly, I would say, delivered SBRT to. So again, this is one of my patients who had a prior history of a right-sided breast cancer about 20 years ago. She had received lumpectomy followed by whole breast radiation. 2 years ago, she developed an angiosarcoma of the chest wall on the right side, and we treated her with preoperative radiation with proton therapy, followed by mastectomy. Unfortunately, after that, she developed metastatic disease throughout her body and was placed on chemotherapy and was doing really well on chemotherapy and essentially had stability of her disease systemically. Eventually, however, she started to develop this one nodule in the left breast, which you can pretty clearly see here, and that was her only site of new and growing disease. So kind of thinking about the ideas of just how we're changing our oligometastatic treatments, we thought about giving her SBRT to this lesion as we really didn't feel there was a benefit to putting her through another big surgery in the setting of known metastatic disease. So this was her nodule here on the left breast that you can see pretty easily. So we prescribed 8 gray and 5 fractions to a total of 40 gray. We gave a 1 centimeter CTV margin and our normal GAMMAPOD 0.3 PTV margin, and then we delivered her treatments every other day. This is what her plan looked like, and so these are actually different fractions that she received. And one of the things that's really nice, and I'll flip back to this picture in a second, is that we actually, because again, GAMMAPOD also in a sense is a form of adaptive planning because we do a scan right before every treatment. You can actually see that throughout the course of her treatment, her GTV size actually decreased with every fraction. So it went from 5.8 cc's on her last fraction down to 0.75 cc's. And so you can actually appreciate this a little bit in these images, how the isodose lines are kind of getting more and more superficial in the patient here. And then on clinical exam, when I've seen the patient back in follow-up, there's clinically no palpable disease in this location now, which is pretty exciting. So moving on to talking about some of our clinical outcomes. So there are some unique side effects really just specific to the GAMMAPOD. And both of these really are related to the suction that's applied for the immobilization. So one thing that can happen sometimes is suction blisters, where basically the epidermal layer can separate from the dermal layer of the tissue, and patients will get a fluid-filled blister. Most of the time, these are very small and often tend to be linear in shape, which usually indicates that there was a small skin fold that we just couldn't see at the time of the immobilization device placement. In general, we're still looking at these women who get suction blisters, but in general, we found that there are some risk factors for these. So generally, patients who seem to have what we call kind of bad skin, but people who have obesity, diabetes, uncontrolled diabetes, people who are heavy smokers seem to be a little bit more at risk than otherwise very healthy women. Again, this is still something we're really evaluating and looking at, because certainly if we knew which patients were going to get it, we would better be able to counsel women about it. We do know that anytime we have to add a silicone bolus in as a filler, that can be a small risk factor, just because they're often, even though the silicone boluses have a very tapered edge, there often can be a very small air gap between the edge of that bolus and the patient's skin. So occasionally we can get a little line of skin blisters in the shape of the silicone bolus. The good news is that these are not painful for women at all. Again, since the epidermal layer doesn't have any pain fibers in it, it's typically cosmetic, and they do resolve with 100% completion after the patient has completed their therapy, and they are not left with any permanent scarring as a result of these. One of the things that's interesting about these blisters, though, is that it's an independent risk for each fraction. So sometimes you may have a patient that doesn't get one for the first, second, or third fraction, but for whatever reason they get one on the fourth fraction in our APBI patients, for example. But we do tend to find if someone gets it on the first fraction, they're likely to get one again on the second fraction or subsequent fractions. And we also know that the risk of these blisters is somewhat correlated with time. So the longer time the cup is on, there's an increased risk. And so it is important as people develop their programs to try to be as efficient as possible, of course, maintaining all of our quality and safety practices as well. So even with all of this being said, the risk of suction blisters is typically 10 to 15%, so it's still a quite rare event, but it is something that some women do experience. The other thing that happens with a much lower incidence is just a small area of petechiae where patients can get that. Typically, if they do get it, we actually tend to find it's kind of underneath the breast where the flange is sitting kind of on the upper abdomen. To be honest, I haven't seen one of these in probably over a year now, but it is something that occasionally can happen as well. And then the last thing is just a little bit of a contact dermatitis from the adhesive on the pink flange. So again, many people, sure many of you in the audience today, if you put a Band-Aid on, get a little bit of a contact dermatitis when you take that off from the adhesive. So again, this occasionally does happen for some women who have hypersensitive skin. And again, if this is bothersome, it's just treated with topical steroids as well. And again, as expected, completely resolves. So what about some of the toxicities outside of these GAMMAPOD specific ones? So we did have a presentation at the San Antonio Breast Cancer Symposium last year, where we actually looked at our first 13 patients who had received partial breast radiation with the GAMMAPOD. All of those patients received 6 gray and 5 fractions, so very similar to the Florence regimen that has been published on, and that accounted for 65 treatment fractions delivered. Again, our median patient age was 67, and all of these women had either stage 0 or stage 1 disease. Radiation was started a median of 52 days following surgery and was completed in a median of 10 elapsed days, again, because we were doing every other day treatments. And so as you can see, if we actually look at petechiae and suction blisters, which we just talked about, those were still, you can see those numbers here, but if we actually look at things that we think about specifically more with radiation, we only had 1 patient who developed grade 1 erythema, 1 patient who developed grade 1 hyperpigmentation, and 2 patients who had some grade 1 breast tenderness, but there were no grade 2 or higher toxicities for any of these patients. So I think this is pretty exciting and very promising short, acute toxicity profile with the GAMMAPOD. In terms of the patient experience, so some of the things that we've heard is patients love having this shortened course of therapy. So they're really excited about the fact that even though we have hyperfractionation for whole breast radiation, that they're actually able to complete all of these treatments in about a week and a half. Again, for many patients who are working, they can just take the time off work, dedicate their time to their treatment, and then go right back to work when it's done. Patients, we often get a lot of great feedback about having very few short-term side effects. If I flip back to the slide I was just on, one of the things to note is that we had no patients complain of fatigue during this treatment. And so that's really exciting for a lot of women, because I think, again, a lot of women know people who've been through breast cancer treatment, and get really worried about the fatigue and really worried about the skin side effects. And so they're ecstatic that they don't really have any of those things. Again, when you look at the immobilization device, I think one of the first things people often think about, and even when I'm training people, is they worry that it is painful for women. And I can truly say time and again, women do not complain of any pain with the immobilization device. It's a little funny and awkward to wear for that short period of time, but they truly are not complaining of any pain with that. Some patients do experience a little bit of neck discomfort while laying on the table. And so we've developed a couple different ways to make patients more comfortable. We have a egg crate pillow that we can give patients. We give ankle support. For women in particular who have arthritis in their neck, they tend to be, at baseline, those tend to be the patients that complain the most about some neck discomfort. And so generally what we do is we just really try to minimize the prone positioning as much as possible. So we actually at University of Maryland will have patients kind of stand with the cup on with one of our nurses until we're actually ready to get them on the machine for treatment delivery. Again, that may vary institution to institution, but we find that to be the best for our patient population. And then again, I already touched base on the suction blisters, but again, the good news is patients rarely report these to be painful in any way, shape, or form. And again, they do fully recover with no long-term skin sequelae as a result of that. In terms of cosmetic output endpoints, so one of the things is the UT Southwestern-led APBI multi-institutional protocol that I've mentioned a couple times. This is actually one of the endpoints that we're looking at. I will add that thus far in the clinical experience here at University of Maryland, as well as at UT Southwestern, we really have not noticed any unusual cosmetic outcomes compared to whole breast radiation. So I truly have not seen any women that have anything unique that I haven't seen with frequency in the whole breast population. And to date, we've had one patient who did have a recurrence, but this patient, in full disclosure, was mostly non-compliant with treatment. So she had a very large delay between her diagnosis and her surgery, and then had a very, very long delay between her surgery and her radiation, and actually had been recommended for whole breast radiation, but refused any radiation at all unless it was partial breast radiation. And I know that may sound a little bit of a funny course depending on where our audience is located at, but something that we do encounter sometimes here in the US. And that patient has been successfully salvaged with a mastectomy at this point in time. In terms of efficiency and workflow, so at University of Maryland, we currently schedule our treatments, or at least for the physician, in 1-hour appointments. But again, there could be very big differences in workflows at each site that are unique to your facility setup as well as your patient populations. But these typically are scheduled in 1-hour blocks, and so we block off our simulator for about 30 minutes, so it's not as disruptive to the rest of the clinic flow. At UT Southwestern, they actually do have 2 CT simulators, so they don't have, I think, some of the same challenges that we do here at University of Maryland in terms of blocking the CT sim off. But again, we've developed workflows around that. There definitely is a steep learning curve when you're first implementing the GAMMAPOD program into your practice. A lot of this has to do with the cup placement, the immobilization device. Again, there's a very steep learning curve for becoming comfortable with using that, minimizing loss of suction and so forth. Again, everyone, I think, moving forward has the good benefits of our experiences here and at UT Southwestern. So I think we've been able to develop a lot of the tricks that help prevent all of that, which again, as some of our new sites come up and running, we'll be happy to share with you. Again, there is a new treatment planning system that does need to be learned. And then I think the other big thing is learning patient selection. So you really have to look at lumpectomy cavity location. And sometimes this also will mean that you need to work with your breast surgeons on, their specific techniques, or if they always say, have the incision kind of laterally as opposed to maybe a periareolar incision. And I know specifically at UT Southwestern, they did work with their breast surgery team a lot to kind of help develop some great workflows that aid in patient selection. One of the other things to mention is just as all of us are dealing with COVID, I think this is a nice time for the GAMMAPOD because, again, due to our shortened number of treatments, there's less hospital or less treatment visits. So of course, that means less potential for exposures. And I will say that that has been very attractive to patients right now in the current climate. You know, if you can tell them they just need to come in 5 times for an APBI regimen instead of, 15, I think that's very nice for patients. And then patients can comfortably wear their mask, during placement of the immobilization device and then even during the treatment as well. So really, what is our vision for the GAMMAPOD? So I think one of the really exciting things about it and one of our goals is to find a group of early stage breast cancer patients where we can potentially treat them with radiation therapy alone, so in a completely non-invasive way. As all of us radiation oncologists know, this is a paradigm that's happened in, brain metastases with Gamma Knife. It's happened in early stage lung cancer with lung SBRT, again, being evaluated in the liver setting and many other settings. And so again, for these women with very small early stage breast cancers, it seems like this is a great opportunity for us to try to do the same paradigm shift. Again, it helps improve convenience of treatment for women by shortening their treatment time. Again, not just in the early stage setting in the APBI setting, but even in the advanced setting with delivering a 1 fraction boost. That can actually shorten treatment time by 4 to up to 6 or 7 treatments, depending on which regimen your practices use. Again, there overall are decreased doses of radiation to the normal breast, which can result in fewer side effects, both again in the short term and hopefully the long term. And we feel that overall this will all improve the quality of life for our breast cancer patients with early stage breast cancers. And then again, because there's a shorter number of treatments, this also has the possibility of improving our healthcare costs associated with breast cancer care in general. And this is certainly a big deal here in the U.S. that people are looking at, and I'm sure in many other countries internationally is something to look at as well. From the patient perspective, the benefits are, again, that it's non-invasive, again, that shortened time, very accurate delivery, so really kind of focusing on our cancer cells, our precancer cells, and not our normal tissues. And then again, there's this access to ongoing clinical trials, which again, the more participation we get in clinical trials means that we're continuing to advance the science and improving our treatments and preventing breast cancer as well. And then there's also a possibility, and again, this is something to be explored still, that could we potentially use this technology to increase probability for breast conservation. So again, as I mentioned, I think one of the great opportunities for the GAMMAPOD is to deliver the radiation therapy preoperatively or in an ablative setting. So again, performing radiation in 1 to 3 treatments prior to surgery. Early on, we'd need to identify patients who have no residual tumor, and then could we then do that clinical trial doing radiation therapy alone. And preliminary work here at University of Maryland shows that this is feasible. So we previously, prior to the advent of the GAMMAPOD, had a preoperative trial which showed a response rate of about 15% using non-ablative doses. And the GAMMAPOD will really allow us to develop ablative doses of therapy and hopefully improve upon this rate. And this concept is being done at several other institutions. So you can see here our University of Maryland data. But again, here's some additional clinical trials that are either in process or have been completed, which also show that this is feasible. And so now's the perfect time for this technology for us to really look at focusing on this concept. In the U.S., this is from clinicaltrials.gov. So these are the open clinical trials that we have right now. Again, these are multi-institutional. This is our partial breast radiation trial here. This was actually our initial study looking at that led us to FDA clearance. This is our boost protocol, and then both UT Southwestern and University of Maryland have kind of preoperative ablative protocols open as well. One of the exciting things about this group, though, is that we have a multi-institutional research consortium of GAMMAPOD users, and so this really allows us to drive these clinical research questions and get this data faster together, because together seems to be the buzzword for the year of 2020. So these are our locations currently. So again, University of Maryland, Baltimore, so this is what our vault looks like, and again, the one that we clinically use. Here on the right, you can see UT Southwestern's, and then underneath here, you can see there's 4 places under installation right now. So Allegheny General Hospital in Pittsburgh, Pennsylvania in the U.S., Ottawa Hospital in Canada, Udine in Italy, and then Shandong in China as well. And so we're really excited about having all of these places come up and running and joining into our multi-institutional consortium.